Vijay, welcome to my podcast.
Thank
It's an
you.
honour to have you here today.
My privilege. It's my privilege. Thank you. Thank you
You,
for having me.
you are a general and interventionalist cardiologist. You've been a doctor for over 40 years and you've been a cardiologist for a good 30 years. You are also have a reputation of being the leading cardiologist of Fiji that I really would love to speak to.
One of the cardiologists
Yes.
there.
You specialise in angiograms and angioplasties as well as pacemaker insertions. So, can I start off with first, what brought you to want to even become a cardiologist? Take us right back to how old were you when you went, I really want to be a doctor or a cardiologist?
Well, I suppose I should thank you again for having me. It's a real pleasure, privilege for me to be able to talk about Fiji. Um, I suppose I should start off how I got into medicine. Uh, I don't know whether people believe that, but I lived very close to the main hospital in Fiji, the Colonial War Memorial Hospital, CWM as we call it, a very historic institution in the Pacific. And I just lived a few houses away from the hospital. So I would, as a boy, get off the bus and pass through the hospital. There were no securities and things like that in those days, and come home. And I somehow got a feel it would be nice to come and work here. And that hospital has become part of my life, since then. And this is even before I started my schooling. And I began to see some role in medicine, that, there's a impact that one can have. I mean, there are all other professions. We can make impact in a lot of ways. I thought medicine would be a good way. So I went to do medicine. I went to India, and I saw a lot of pathology there. And I did get interested in cardiology over there as a medical student, but there's so many other things one could choose. But I came back to Fiji doing my internship and my residency years, house surgeon years, you want to call it, registrar years. We had amazing general medicine. Cardiology remained a very big part of our work. So it was an interest that if I could specialize, I would like to do cardiology. But in those days, we could not come to Australia or New Zealand for training. It was very difficult to get here. Eventually, I was able to. I managed to do so after about 7 years working in the hospital. So we do general physician training. I took a year to do infectious disease. I thought that might be more relevant for Fiji, but somehow I ended up in cardiology again.
And how long did you specialise in cardiology at CWM Hospital?
No, cardiology training was in New Zealand, in Wellington and Auckland's Green Lane Hospital, and I've subsequently also worked in Canada. But then after I finished all my training, I came here to the Gold Coast, and I've been a cardiologist here. And I realized the need for work in Fiji, so then I got involved in medical and cardiac work in Fiji, and eventually ended up with the heart unit that we have there.
And being a cardiologist is obviously very rewarding and being able to help somebody in their most traumatic time. So what are the sort of qualities that are needed in a cardiologist? Because your days are busy, they're long hours. You need empathy with these people in these traumatic times. So describe it, how you need to be a really good cardiologist.
I suppose the qualities that you just spoke about are things we should strive for. I don't know whether I achieve them or not, but I think these are things, values that we should all aim for in whatever profession. And cardiology is one part of medicine. There are so many other specialties. But I think cardiac disease does become a very big part of our work today. More people die from heart disease than any other condition worldwide. That affects the developing countries, the developed nations, but 20 million, almost 20 million deaths a year from heart disease. And the other thing is that there is so much that is possible in cardiac disease today. Someone comes in with a big heart attack, some damage will persist, but if that person comes in very quickly, he gets the right drug, and in our centers here, he gets into the cath lab, gets an urgent angioplasty, stent, the artery is open. The benefits are there compared to the sad end results that we saw in the past. We still have them. We are putting pacemakers, we're treating rhythm problems, the medical management of conditions has improved so much. The surgery has also improved, congenital heart disease surgery. So the impact of cardiac disease, while the huge challenges, the opportunities and what you can do in cardiology and medicine in general is great today.
And there's so many modifiable risk factors people can work with too,
Of course.
even for prevention.
Yes.
Because having worked in cardiac rehab, the education always began after the event.
Yes.
But it was amazing and incredible how many people would say, "Oh, Alex, if only I knew this information before I had a heart attack." Because there's so many things people can do, but I don't think they realise that they can make such a change prior to the cardiac event.
Absolutely. I mean, that is if we could achieve all that, then,
Yeah.
so much. That I
No
think
heart disease.
80% of heart disease of the cardiovascular type is preventable, I think. Statistics will give you different figures, but close to 80%.
Yeah.
So if we all, did the right things, ate well, lots of, fruits, vegetables, as much unprocessed foods as possible, regular exercise, did not smoke, monitored our blood pressure and cholesterol, and if needed, took the right medications. I think so much of heart disease will not progress to the need for the stents and the bypass surgery and all that, and deaths.
Yes, and deaths, and preventably. Where, now, you work a lot in the Gold Coast, but what fascinates me is the role that you play with other nations. For example, you've spent many years in alliance with creating one of the first cath labs and cardiac centres in Suva, Fiji. So where did that idea, take me back to when did that idea first occur to you to create a cath lab in Fiji?
Well, it was a kind of, sad nostalgia. Because I was in Fiji, working there for 6-7 years, and Fiji, we see a lot of amazing medicine. Sad things because we don't have all the right facilities and staff, but we did our best. We worked under some great clinicians and colleagues, and we had a patient come in, say, with a heart rate that was very slow. We knew something about these things, but then when they would go home and die, and we gave them a few drugs which might speed up their heart rate. The heart attacks came, all that we could do was give them eventually the blood thinning, so clot dissolving drugs did turn up. But, these were not the best, and they were given to only about half the patients who needed them and all that. So that was sad. And then when you come to the West, when you come to New Zealand, you come to Australia, you see what is possible, what is available. And then you say, okay, these are not easy to replicate, but we can still do better than what we have in Fiji. And then I joined the Sydney Adventist Hospital's Operation Open Heart team. And I was the screening cardiologist with the team. It was quite an honor. And I worked with the surgeons and others who went to Fiji. And these were big teams. They were seeing only rheumatic heart disease patients. So places like Fiji, the whole of the Pacific, parts of Australia and the Northern Territory, and other places, we have a lot of rheumatic heart disease. And rheumatic heart disease in these communities affects young people, as against many in the Caucasian world where it would be affecting much older people. And rheumatic heart disease is a disease of poverty. So we don't see that much in, big cities in Australia, New Zealand, America, Canada, where it was a big problem in the early 1900s, 1920s and things. So I started working with them, and the rheumatic heart disease issue was massive. But then I also knew from my work in Fiji, all these people dying from heart attacks, and young people, you see. And we have the coronary artery disease incidence in Fiji is about 4 times that of Australia. 4 times that of Australia.
That's huge.
That is huge, And this, I'm talking of men and women. So it's not the correct analogy, but if we have a population in Fiji of 900,000, you are looking for at least, say, a city of about 2-3 million people. And say Brisbane, I don't know how many heart surgeons Brisbane has, how many cardiac centers it has, how many cardiologists it has, echo machines, this, that. In Fiji, we have finally created 2 cardiologists, right? We don't have, we started some sort of heart surgery, but it's not ideal, but there is some heart surgery there. And we have, in the public system, we might have about 2 or 3 or 4 echo machines, 2 treadmills, and 2 doctors stretched to the limit,
2
2
cardiologists.
cardiologists, and we have a cath lab in the public hospital which runs on, held together by sellotape. I will keep saying that, and by the grace of God, divine help. But, that facility could do 10, 12 cases every day, and still will be, having people to do. So there's so much work there.
Yeah.
And so many people who need that. I emphasize prevention and the medical management very, very strongly. But if you work in Fiji, you will realize there is such a big population that needs to go beyond that. And that's one of the reasons to start the cardiac service
So
we
just
tried.
break it down for the audience, rheumatic fever, and what is it and how does it affect the heart?
Right. Rheumatic fever is condition where one may remember a sore throat, but not about 50% of people do not remember that. But it actually starts with infection by a particular bacteria called streptococcus. Strictly group A beta hemolytic streptococcus, as it's called if you identify it on the Vega plate. And that gives you a sore throat, but as I say, half of the people don't remember ever having had that, or the subsequent rheumatic fever that occurs. So 2-3 weeks later, in the classical scenario, you develop rheumatic fever, and that is you can be febrile, feverish, and you have a joint involvement. And the joint involvement is in the classic variety. It's fleeting. So it might be the ankle today, the next day it'll be the elbow, it could be the knee, and sometimes the heart is involved also at the time, and it's called carditis. So you could go into heart failure. You may develop inflammation of the membrane lining the heart. A few other characteristics we see. You can develop a rash, a particular type of rash, some neurological movements like chorea, as we know. You think somebody is doing some purposeful movement, but it's involuntary. So all these things are part of the rheumatic fever episode that occurs about 2-3 weeks later. But many people don't remember the sore throat, nor this rheumatic fever. And then a few years later, you see the involvement of the valves, the mitral valve in particular, more so in women, and then the aortic, and sometimes the other particular tricuspid very uncommon. So the mitral and the aortic valve over time, they are affected. There are certain characteristics on the echo machine, you can pick that up, and all this happens in a very short period in Fiji, in Samoa, in Tonga. But if it happened in the West, there'd be a long gap before
Yeah,
you find
decades, isn't it,
decades.
delay?
Yeah, and these people are very sick, very critically ill. I think the old pathology textbook that I read said rheumatic fever is a disease that licks the joints and bites the heart.
Licks the joints and bites the heart.
Yeah.
Yeah, because it renders those valves quite
Yes, the valve
incompetent,
is
doesn't it?
tight
Short of
or
breath.
tight
Yeah.
or leaky, particularly the mitral valve, as is common. Often it is the first valve that's affected.
And they're
They
pretty
get
much heading towards a valve repair or a
yeah,
replacement.
they get very short of breath. Then their rhythm becomes irregular, so they become worse. We see a lot of rheumatic heart disease in Fiji. The tragedy is that in the facility that we tried to create, I had hoped that we'd have an understanding of why all this is being done. Rheumatic fever is still a very, very big issue in Fiji. They have developed a cardiac surgical unit in Lautoka without any proper medical input or planning. And unfortunately, that facility does not do any rheumatic heart disease surgery. That's unacceptable, I think, because when I used to go with the Sydney teams, we had so many patients with rheumatic heart disease. And to imagine that since they stopped coming because of COVID, we have had hardly anybody in Fiji operated on for rheumatic heart disease. So I'm not sure how many people have died, because I would be screening about 150 patients, and I'd have to screen about 50 for the surgeons, and the surgeons would then decide. We all sit down, and then we decide on about 30, 35 patients for surgery. Of those 150, and I've chosen 50, my colleague who took over my place and who was before me, the screening cardiologist has already put 100 out of the list, and many of them you may never see again. So it's
So
very
where were
sad.
these patients going prior? Because at the moment your Colonial War Memorial Hospital has no cardiothoracic capability at all.
Mm-hmm.
But you're saying Latoka, which is further out of
Yes,
Suva, does,
yes.
but they're still not doing
Rheumatic
rheumatic
heart,
heart
yeah,
surgery.
yeah,
So
yeah.
where do those patients go?
It's
Are
all
they flown to Australia and New
no,
Zealand,
no.
or
There's nothing there at the moment. This is all cart before the horse. You know,
yeah?
some politician decided that Fiji needed bypass surgery, and the whole thing was 24/7 bypass surgery. I mean, in an ideal world, yes, Fiji does need 24/7 bypass surgery. Then there was this talk that we'll be treating heart attacks now, you know. Heart attacks, are, as you know, Alex, are not treated by heart surgeons, you know. Physicians, cardiologists treat heart attacks, you know. Emergency doctors treat heart attacks. And in Fiji, you might go for thrombolytic therapy, clot-dissolving drug therapy. And if you were to develop a 24/7 facility, it would be a cath lab, you know, not a cardiac surgical unit, you see. So there's no, cath lab is not supported in Suva, and you end up with a cardiac surgical unit in the second biggest hospital in Fiji. It is a busy hospital, but nowhere near like CWM. It is the biggest hospital in the South Pacific. And all these teams, the majority were coming to Suva. The Sydney Adventist team came to Suva to operate. They started in 1991. They were coming every year. Amazing group of people, you know. Australian surgeons mostly, but there are sometimes doctors from other parts. New Zealand, Fiji Indian surgeon from New Zealand, he used to come. He came about twice. Before that, the New Zealanders came. I was intern in 1980 when the first team came from New Zealand. And 1982 was the second, then I think 1985, and then the New Zealand team stopped coming, and then the Australian. But there was a surgeon in Fiji, can you believe, who could do some rheumatic heart surgery, a local Fijian surgeon. So we had the capability, and this brings up the issue that the doctors and nurses in Fiji are very well trained and very capable. That is something perhaps I recognize more than a visiting doctor would, because I'm part of the system and I've worked with them, and it's a real honor and privilege. They're amazing people, and they just need that extra training, and they will uplift, as we have seen in our own work, you know, that they become, they get skilled very quickly, upskilled.
Yeah. And your work has predominantly, you've had so much help, but it's all been private enterprises that have been helping as well create this cardiac clinic. So you had your first cath lab machine in 2009, then 2014 was the second one, and 2022 was the third one.
Yes.
But this has all been from donations and secondhand equipment that's been donated, hasn't it?
Yes.
Like, to create these whole cath labs from nothing has been absolutely phenomenal, but it's taken a lot and a massive army of
It is.
volunteers that are private. So my question then is, has there been any government help either from Fiji, Australia or New Zealand?
Yes.
Because it's a mammoth task to not only set these labs up, but also just to continue operating them. You need consumables, you need all this ongoing financial support. So where are you getting that from, Vijay?
Alex, I might just stop. You've been in the cardiac field, I've worked with you. You have summarized all this so well, every word, honestly, you know. And this whole thing is a big exercise. I sometimes call it a military exercise. The number of people, the problem that we face, the different, you know, areas that you have to tackle, you know. So I think the issue was if somebody realized the need for it. You see, I can't expect a politician to understand the nuances of medicine, you know. But if the political people in charge realize why, and you know, I don't expect an ophthalmologist to understand what I'm doing, or an orthopedic surgeon, right? But being in the field for so long, being local, having worked in Fiji for 7 years, and I knew the capabilities, what's possible, and why this was needed. I think that support I did not get. The government has been very friendly. They've allowed us to do things, but they've never got behind the project. There now some, you know, comments and some hope. But the one thing that I've asked for, let's sit down and plan this whole thing, because this requires strategy to move cardiac care, not just the cath lab, but the whole project forward, you know. And I've been involved with heart care in Fiji since 1994, by the way, you know. And the cath lab project we started in 2007. Now, we have never really had a proper planning meeting, you know. And the present minister has offered, that. He actually, the last time I said, let's do this.
The Minister of Health?
Yeah, current minister. And we've actually prepared a document which we'll hope we can discuss with him. He's busy with the WHO meeting in Fiji this week when I'm going, so unfortunately he can't do it. But I'm sure we'll work. But this has to be ongoing, this whole thing. When we installed the third cath lab in 2022, the current Prime Minister, Mr. Rambuka, he attended my presentation. And after that, he said that if his government came to power, he would want a national cardiovascular center to be set up at the CWM hospital, and he would invite me to help. So I thought that was very important.
That's
he realized
positive.
the need. Once he realized the need, he also realized that this has to be at the CWM hospital, nowhere else. Nowhere else.
Correct.
If you put it anywhere else, you don't understand how healthcare
It's the
in this
biggest
country.
city, it's central, it all
You
needs
don't know.
to be
You
there.
don't know anything about medical cardiac care if you kind of put up things in other places and with a surgical unit which is not as that necessary as the rest of cardiology. And then he asked me, well, he probably realized this fellow has been involved in cardiac care for so long. He comes from the field, he's local, so he'll probably a good one to be part of the project.
Yeah.
So that has not happened yet. We keep reminding this government that these are great words that you put up and a great strategy that we would love to become part of. I think there were not other issues to handle. I can understand that.
So that's your planning strategy, isn't it? Is that you've got the 3 cath labs now. You've got
the third cath lab. Every year we just only have one cath lab at a time. The others they're old cath labs, so they have to be discarded. A new one put
I
in.
see.
A new one put in.
Okay.
We have only one cath lab working at any one
Yeah.
time.
But again, that. Correct me if I'm wrong, but that's only open 2.5 days a week, isn't it? This cath lab.
Yes.
Where really it should be open 7 days, 24/7, needs to be activated
It
in
should
the
be
case of a
open 14
primary
days a week.
coming in.
It should be open 14 days.
14 days a
we have
week.
that much work in Fiji.
Yeah.
That much work. But we now have a local vascular surgeon, Dr. Sela Koya. I forget his surname properly, but Dr. Sela Koya. He's come from Melbourne, an amazing local Fijian cardiac vascular surgeon. So he is using our cath lab on Thursday and or Friday. So vascular surgeons often do cath lab work too. And we're very, very happy with that. And we work together, and our cath lab is vascular capable. So, Fiji is the amputation capital of the world.
Fiji is due to diabetes?
Diabetes and other things. So we have, I believe the Norwegian WHO team told me that a few years ago. They were visiting, they could not believe what was going on there. So we have amputations occurring every day. Not that we'll save every amputation, it's risk factor control, diabetes control, but a fully qualified vascular surgeon can make a significant difference.
Now, you also talk about the late Dr. Paul Farmer and that he was so instrumental and a mentor that you actually looked up to. Can you sort of explain to the audience what Dr. Paul Farmer's role was?
The late Dr. Paul Farmer, he died most probably of a heart condition, I think, when he was in Africa doing some of his inspirational work in Africa. But he founded the organization called Partners in Health. He was an anthropologist and medical doctor in America, internist, and he went to Haiti and he saw the very dire health situation there, and he set up a hospital there in not the capital but some rather remote place, and he tried to deliver high quality health care to the people there. And he said, I may be wrong, but I think he did say cost effectiveness can be a dirty word, because you create a barrier that, okay, this is a developing country, we can't offer them technology, we can't offer them, that's too much for them, something like that. So he said, no, we may not be able to replicate everything that occurs in the West's big medical centers, but we have to strive to do our best to uplift care beyond just the basics. And he tried to do that. And I think when you look at, we can never compare ourselves with Paul Farmer, but some of the work that you see in Fiji and in other parts of the world to develop a higher quality care is to bring medicine that you see in Australia, New Zealand, Canada, America, England, Europe, bring some of that to these. Why should they be denied the immense benefits of modern medicine? Why? And that's the goal of our work in a small way. Paul Farmer tried to make that his whole gospel. Yeah.
And especially when you see equipment in first world countries having an expiration date, and
Yes.
yet they're totally workable, usable.
Absolutely.
And to be able to bring that to another country as well,
Yeah.
and donated for free, and have that running so that those residents and population can actually have as equal health opportunities, and so
Absolutely.
that you're getting rid of the disparities, isn't it? You're trying to
Yes.
close that gap.
That's right. Yeah, I totally agree. See, I don't mind using the second-hand equipment story because, in a place like Fiji, the Fiji government or similar government started buying all this equipment. It's too expensive. And, the cost, you got other priorities. You got roads, you got education, you got other aspects of healthcare to look after. Now, we have not paid a cent for the 3 cath labs that have gone to Fiji. Removing them from the hospitals here. I showed you the video. What a big exercise it is to put it in a container, take it to Fiji in a ship, and then removing it there and installing it. These are massive exercises,
And the equipment weighs a
equipment,
ton.
2 tons, and then to do all that, and yet we have done all that at no cost.
That's incredible.
Believe me, not a cent to the Fiji government. Now, how much money we've saved for that country or another country where this is being done, and that money can now be used for other aspects of healthcare. Our oncology service is so, we need so much. There's so much cancer disease, and we have hardly, 1 or 2, from what I remember, 2 oncologists for the country. We don't have radiotherapy there. Our roads, our education, all that needs. So if we are saving money here, we would like to feel that we are really contributing to national priorities and national requirements.
Absolutely.
But then you see in the other hospital in Lautoka, they've got a cardiac surgical unit that is fully funded. We don't apparently it's all free to the patient, but the current deputy prime minister made it very clear that that arrangement in Lautoka was costing the Fiji government, it's not my comment, his comment, 1/5 of the health budget of the country, going to that and another sister hospital in Lautoka in Ba. So can you imagine how cost effective, how well planned this whole thing would be when 1/5 of the health budget is going to one major and another smaller hospital
My
in
goodness.
a country like Fiji?
But hang on a minute, it doesn't make sense. So you've got your Colonial War Memorial Hospital, which is this in central Suva, and it's got a cath lab for acute coronary artery disease intervention, doing angioplasties.
We
and
can't
yet,
do we
And
we,
yet,
yeah.
if that developed into coronary artery bypass, you can't even do that there. You've got to send those people to Lautoka.
Yeah. In a hospital which has done by heart surgery since 1990, 1980 in a way, 1991 on an annual basis.
Yeah.
Often 2 teams, sometimes 3 teams, with an Indian team coming to do congenital heart also. So this hospital, it is a stretched unit. There's no doubt. It's a very stretched service. It's a cramped area. It's sort of built in sections. It wasn't one planned hospital. And the Australian government is behind a project where we might be getting a full, brand new national regional center for the Pacific. And
In Suva?
In Suva. So the Australian government is doing a lot of work for the CWM hospital and to make it more
Right.
functional, because it's been really run down.
Yeah.
But it's not just the painting and the lifts that are required to be attended to. I think they have to look at the strategy. What is the healthcare? I mean, they should see, somebody should question, what's this surgical unit doing in Lautoka, without a cath lab, without a cardiac unit in the beginning,
Yeah.
How did that happen, So they should advise on healthcare planning. Not just to say that, okay, we're just here to prop up CWM hospital, which is, I think, the prime role. But how Fiji does not have the expertise to plan healthcare. It does not.
That should have all been in the planning.
Yeah.
It should have
And,
been
I would have
centralised.
hoped that, Australian authorities would have seen what we have done in our setup. There's not just cardiology. There's a very good setup in gastroenterology. And my senior colleague, Dr. Malani, got involved with Professor Finlay McRae, senior gastroenterologist from Melbourne, and they started a gastroenterology service with the World Gastro Organization, and we have local doctors in Fiji doing very high-level gastroenterology. And we have done that in renal disease too. So there's a lot of goodwill. There's a lot of people who are volunteers, and this can be tapped into to make it a bit more formal, a bit more organized. And I think Australia could provide help in planning and in strategy. Yeah.
And the success of CWM Hospital has been phenomenal already. You've done over 7,000 angios, over 200 pacemakers, and 700 to 800 angioplasties, which is where they pop the stent in for the audience.
Yes.
So that's huge achievements that have happened.
With very limited resources, sometimes we don't have equipment there. Our pacemaker work is very important, and I would say that I was among the first to start the pacemaker service there. But we had a colleague of mine from my Auckland days, Fiona Riddell, who was a very senior pacemaker scientist, technician, physiologist, if you want to call it that, and she amazingly looks after the whole pacemaker setup in Fiji still. And she's helped set up the Pacific Island Pacemaker Service called PIPS. So they come twice a year to Fiji. Usually about 2, sometimes 3 doctors come. They come with nurses, technical support, because pacemaker is not just implanting. It's the testing the device at the time, follow-up that occurs once a pacemaker is implanted over years. So all that is, she has been instrumental in creating this service. Now, we have a doctor from America. In the last visit, I was there with them a few weeks ago. The team was there. It was a real privilege to work with them, many of whom I know. And 2 of the doctors are from the US, one based in America. The other is an American doctor who now is in Christchurch. And to work, and all is done free. No one's charging any money for this, you see.
Incredible.
And the thing is, we did about 22 devices, 20 to 22 devices were implanted. All except one were done by the local team.
I was going to say, so is there a legacy that
This
the
is-
international
Yeah.
EPs are actually training the
Yeah,
locals?
we are the only place in the South Pacific where there is a full local pacemaker service, skeleton service, but still done. So now when the New Zealand team comes, PIPS, instead of putting 20 new devices, they're putting about 6 or 7 new devices because they are being put during the year. A pacemaker is not going to wait for you.
Yeah, brilliant.
So our local 2 doctors are able to put in pacemakers as and when the need arises.
Brilliant. Now, you also told me a fascinating story of how you got all the echo machines, but you met an incredible lady from another island. Can you sort of
Yeah.
share with us how?
Well, the
how you
number
got
of
all your-
incredible people that we have met in this journey is, Alex, is just amazing. So, to have a cardiac unit, there are many aspects to a cardiac unit, You need sound clinical knowledge, medicine, practice that. But you also need a basic ECG, so important still, a treadmill test, a treadmill facility. Ultrasound is a very big part of our work today, an echo scan, as we call it, echo machine. So we had 1 or 2 people who could do echo in Fiji, 2, 3, 4 people, and these were doctors, right? And if a doctor is going to do echo, you are taking the doctor away from so much else. He's got, in a place like Fiji, doctor is so precious, particularly cardiac-based doctor. And we had very run-down echo machines, that probably didn't work that well too. So in the other island, we have our 3rd biggest hospital in the other island. It's called Vanua Levu. Our big island is called Viti Levu. So on Vanua Levu, on a Sunday, this American lady knocks at the hospital there and said, "If you do you people have an echo machine?" She talked to our our doctor there, physician, who's now our Fiji's senior oncologist, Dr. Ane. And she said, so Dr. Hani told her that, yes, we have an echo machine, but we don't know how to use it. So she said, I'll come on Sundays or weekends to teach you people, because she was a Peace Corps volunteer.
Wow.
So she was, I can't remember where, but she was in some village doing some other work. So she would go to Lambasa Hospital and teach them echo. So in one of my phone calls to Fiji, which I make from regularly, I spoke to Ane about a patient. And she told me that, hey, we are so fortunate. We have this American Peace Corps volunteer who I believe, I may be wrong, was head of echo at a university hospital in Madison, Wisconsin, Carol Fox. So she is coming and teaching us echo. I said, no, she's not going to teach you people echo anymore. I said
She's
no.
coming to Suva.
So she's coming to Suva. She'll train Fiji now. So Anne understood. And we had a minister for health at the time who was Dr. Neil Sharma. I think much of our cardiac work occurred when he was minister for health. He understood a lot of what we were trying to do. So he asked me to give me a job description. He approached, if I remember correctly, the U.S. Embassy and the U.S. Peace Corps Service, and we got Carol to Suva and put her in our hospital. And as she joined, we sent 3 used echo machines from here, from Gold Coast. And that started our echo service. So she trained our doctors, our technicians, our sonographers, hands-on for a whole year. And I think one even passed an American exam, you know. So our
This
echo
is local technicians.
local technician, yeah. So our echo service is her legacy.
Brilliant.
Yeah.
And I think also the sonography, not the sonographers, no, the echo machines is now grown to about 17.
No, they're not 17 altogether. 17 have been sent
Yes.
on this scheme because when these are old machines, everything is second
Yeah.
hand there, but they run very
There
well.
is an expiry date
Yeah, they
after
have
all.
an expiry date after all. Yeah, I wish they could go on forever. But so when the machine's about to go, we find a second. I've just sent one from our hospital here, and that went a few months ago. So it keeps the cycle running. You know.
Yeah. And I also heard you were talking on a podcast and you said, we've only got, so in an angiogram and angioplasty, you need a sheath. For example, these are consumables for the audience. And you were mentioning, there's only 3 left.
Yes.
And what are we going to do after that? Like, you're so dependent on this management of constant consumables
Yes.
coming onto the island, isn't it?
Yes.
So how is that managed? And if it's only open 2.5 days a week, there's a real need for it to be open 7 days a week.
Yes.
But 2, we need all those consumables coming over on a constant basis, don't we? So
Yes.
are those consumables only solely coming over by all the expertise and the specialists that fly over from other countries?
We do take a lot of our equipment. One of my colleagues, Fiona Fu, every time she comes, she brings about $50,000 worth of equipment. I take a lot, sometimes that much, sometimes a bit less. So we get donated equipment. We do send. That is a big part of our, equipment there that we use. But it is something that we can't say we get what we take. Sometimes not exactly what we need. So we have been doing this for some time. And one of the companies, the senior representative, came up to me once and he said, no, we need to know exactly what you need. So he came with me, virtually forced me to go. And we went to Suva and we saw what they needed. And then we started trying to send that to Fiji. But that's always been difficult because it doesn't go through a tender process, which the government insists on. And it amounted to about 475,000 Australian dollars worth of equipment coming to Fiji for 25,000. So again, we are saving so much money.
Incredible.
And this is the best equipment in the world, the best stents in the world, best guide catheters, best balloons, So you're not compromising on, and we're getting them almost free, But the administrative hurdles were very big, and we've still not been able to fully overcome them. So the government has a service, a pharmaceutical agency, procurement office, which buys these things. But it's a cath lab cannot wait for 6 months.
No.
Cath lab cannot wait for 3 months. So these type of things, the administrators will not understand, and I don't expect them to. But if we had a strategy, if we had people who knew how a cardiac service works, how these things have to be replenished. I mean, if you had a cath lab in Australia and it had to stop for 3 or 4 months because the sheath was not available, I think the whole government might have to resign, you know.
Absolutely. And you're also replenishing before stocks go too
Yes,
low. You're not
absolutely.
waiting until I've only got
No.
3 left.
No. And the other thing is we would love to offer the same service that we have in Australia, New Zealand. Somebody comes with a heart attack, goes straight into a cath lab, gets the angioplasty. We've done that a few times, but Fiji is not geared up for that right now. So what we want in Fiji is strong preventive measures. At the same time, there's such a big population needing the other treatment. So we would like a very good thrombolytic service, the clot dissolving drug service. Even here, if a patient comes in within an hour of the onset of symptoms, the science tells you that the thrombolytic therapy is as good as a stent. And if we have a patient, we do have occasionally patients coming from quite remote areas, and by the time they come to a cath lab, they have missed that early period, golden hour, or what you want to call it. So they are given the thrombolytic, the clot dissolving drug. So we want a very good heart attack service where we have good paramedics who save so many lives everywhere, a trained paramedic service, an ambulance service which can give thrombolytic. And we want to go beyond the thrombolytic we have in Fiji called streptokinase and offer the other one, tenecteplase,
Tenecteplase.
so just a bolus, easy to give, doesn't cause hypotension, allergy and all that. Bring them to Suva and Lautoka. I think Lautoka needs a cath lab too, no doubt. You know, they have a cath lab which is fully equipped, fully staffed,
They need
brand
the cath
new.
lab, you need the cardiothoracic
Yeah, but they have a
surgery.
brand new cath lab, by the way.
Yeah.
Totally equipped, fully, just like here. If you went
Right.
into their cath lab, you think it's exactly like here. No holes barred. They got all the. They even got an intravascular ultrasound machine, IVUS machine.
Really?
It just blows me away that you get an IVUS machine in Lautoka, and we didn't have sheaths to put a catheter.
Yeah,
in, you know.
wow.
So I think we need a good heart attack management plan, and we should then choose our patients. Everyone's got a heart attack. Why should he not have an angiogram? Within very short period, if they continue having symptoms or they're not stable after the clot dissolving drug, they get a rescue procedure. Otherwise, a facilitated or whatever procedure to clear any unresolved blockages in the arteries.
So, is there also still a shortage of local cardiologists there? I mean, you have mentioned 2 cardiologists there. Really, that team needs to grow. Is there any more young cardiologists coming up through the wings there?
We are struggling. We have thought of some of our doctors who we would like the young boys, girls, ladies, women to join us, but we have a limited limited pool of doctors in Fiji who are after they've finished the medical training, who go into specialization. They go into other fields too, surgery, anesthesia. They go into kidney disease, gastroenterology, or they might go into general practice, So we don't have too many people. So we do have other people in the cardiac unit, but not everybody does procedures. Our head of cardiology is an amazing woman, Dr. Sukafa. She's an administrator, she's a clinician, she's an echo person, We have 2 other doctors who are also more into imaging and things rather than procedural work.
Rather than intervention?
Yeah, and in Suva, we have one. The other doctor works in Lautoka. So in Suva, we have only one procedural cardiologist. The other doctor comes to Suva for angioplasty because they haven't started angioplasty in Lautoka yet, But when they start, he'll probably be based mostly in Lautoka. So we would like more.
Which leaves a gap.
Yeah,
then.
what we could have is, instead of giving a whole service to some public-private partnership and calling it a service, I think if the government employed doctors, or had an exchange scheme where, if we had a system with the College of Physicians, the College of Surgeons, the Cardiac Society, where, a cardiologist could come to Fiji for a month at a time, be based there, registrar coming and working there, they would see so much. And at the same time, that will keep the service running, And that could be something in other areas too, oncology, surgery, kidney disease, you name it, Our linkage, there is so much that we can do by linking up with Australia and New Zealand. We must change the boundaries of our thinking, I think,
Yeah.
and our endeavors.
I
That's
think
an article I remember, changing boundaries.
now you also talked about, because your work doesn't just isn't just limited to Fiji.
Mm-hmm.
You had a chance encounter as well
Yeah.
with somebody that you bumped into almost, that you read about and then bumped into,
Yeah.
but was also going in the creation of creating a cath lab in Samoa. And
Yeah.
again, like this divine intervention comes, Vijay.
Yeah.
So can you tell us about how that
Yeah.
came about?
Sure. Well, Samoa will have to be Samoa's initiative, Samoa's baby. But we have always felt that, our work should reach out into the Pacific, And among all these small, small countries, Fiji is the most advanced and the biggest and with the best facilities, In an imperfect world, we have a very good medical school. We have, been doing things in Fiji for a long time. All these visiting teams have been coming to Fiji, plastic surgery, you name it, So we can reach out and we could become a training ground for many of these Pacific countries, So when I heard that the Minister for Health from Samoa had come to our hospital, Gold Coast University Hospital, and with him was Dr. Satu Viale, who I have known. He trained in Auckland just as I did. He's a fully trained cardiologist and he's based in Samoa. So these are very rare individuals, And when he was with the team, I did want to meet them, because I said, what can we do? Because they know about our work, we know about a bit about Samoa. In fact, I was wanting to go to Samoa, then COVID came along, So I tried to meet them and trace them in Brisbane. They were busy and they had moved to Brisbane and they had some functions there. So when I went, Dr. Satu said, we're buying a cath lab. I said, I hope we don't have to buy one because there's a one coming up from Auckland. And one of our colleagues, Dr. Peter Roygrock, an amazing man who's done so much for cardiology in Fiji, he took our doctors to Auckland for a year each and trained them. So there is a cath lab coming out from Auckland, which has not been used that much. It's not a Philips machine. And I spoke to Dr. Viale Satu, and I think from what I remember, now it's between Auckland and Samoa.
It's en route to Samoa.
No, it's up to between them. I think they've accepted it. Samoa has accepted it. They will. There's been a change in government, so I don't know how that affects all this, but I think they will not. Samoa is very proactive. The government is interested in doing all this. This is
Right.
This has been something I've been praying for, in Fiji. So the government, the health minister himself was there, and they want this to happen. And Satu is leading the charge there. So apparently this will go into their main hospital, and I think we will be happy. I think Auckland will be very happy to train their doctors as they did two of ours. And what we can offer is improvisation and training in a resource-limited setup. So hopefully we can join in some aspects of training doctors or nurses from Samoa. And this is something, I hope the big brother here is Australia. They should do lateral thinking. The health authorities, the foreign policy directives from here should see the benefits of all this. This is not money so much. When people talk of public-private partnerships, ours too is a public-private partnership, but without any money involved.
But I think you're right. It's Australia can lead the way by being big brother in terms of a reciprocal
way.
sister hospital.
Yes.
Come over to Australia
Yes.
for 6 months,
Yes.
come and learn the skills,
Yes.
take that back, have our cardiologists
Yeah.
go to these island nations also and give their invaluable expertise to help train the local cardiologists there too. And I also see that Fiji is such a great template, isn't it, for all the other islands.
Yes.
This is what's worked, this is how we succeeded.
Yeah.
Just copy this template.
Yeah, it would not be that expensive for them to come to Fiji, live with us, work with us, compared to coming here. The cost, the travel, the accommodation would be much more difficult, And
It's just implementing a reciprocal scheme, isn't
yes,
it? That
definitely.
and it's nice to hear that the Samoan government is so proactive in this initiative.
So I've been in touch with them, but now I've not heard. So when Samoa is ready, I think Samoa is now connecting directly with my New Zealand friends and colleagues. So I think once the machine goes there, it will be installed by the company that the machine belongs to. It's not a Philips machine, it's a Siemens machine. So they will do a full installation. I think they'll have a service contract and all that, which is something we use Philips machines, and we have Peter Koons as I said, there are two Saint Peters in history. One was with Jesus, and the other is this Peter Coons, Saint Peter, who looks after our cardiac unit in
The
Fiji.
second Saint Peter.
Without his help, the cardiac unit in Fiji cannot run. Cannot run. As anything happened to the machine, he's there to look after it. Imagine we've been running it since 2009, 3 machines, one, second, third. He's involved in the installation of each one of them, and he's looked after the facilities. Our images are very good. We've been able to do all these procedures. When things go wrong, we ring St. Peter.
And you've also said that Rotary has been so influential
Oh,
and instrumental
amazing.
in this achievement,
so
haven't
much
they?
to talk about. So I didn't mention Rotary, but the Rotary Club of Suva in particular have been our guardian angel. They have been with us. They've believed in our work. They've supported us. They've helped finance some of our work, and they've given us that moral support that no money can buy. When our doctors, our nurses, our technicians, our doctors go from here, they take them out for dinner. They come and meet us. It's just so encouraging to see that their work is understood, recognized, and supported. Yeah, the Rotary Club is just. And I've spoken to Rotary clubs here too, talked about our work, and I'm really, really grateful for what Rotary have done. Yeah.
Mm. I did a presentation at the Rotary Ashmore the other week and met
Yes.
somebody that knows you. Sung your praises. So just going back to Suva with its high incidence that they're 4 times higher the rate of cardiovascular disease to Australia and also diabetes, what type of education are they getting at all in terms of all the modifiable risk factors?
Yeah, see, because I go for frequent visits, but I go for short visits, and my work is mostly clinical and procedural. I don't interact much with the very important wider aspects of preventive care, which we know is emphasized very well. And I think we do get that message out. The Fiji government does that well. The advice about diet, about health, exercise, the walkathons and all that. So the message does go out, but we still have a lot of diabetes, in Fiji. Among the worst diabetes statistics, numbers and complication-wise in the world. We have a lot of hypertension, high blood pressure, stroke, vascular disease is very common. So diabetes, Dr. Paul Zimmet, I heard him talk, and he was one of the world's great diabetologists. He used to come and work in Fiji with my boss there, Dr. Pashuram, and I think he defined diabetes as a condition where there is excessive cardiovascular morbidity and mortality, where there is also an elevated blood sugar, emphasizing the cardiovascular side effects and complications of diabetes.
Yeah.
So any diabetic, you would say in Fiji, there'll be some vascular or other problem, very likely, or cardiac stroke.
Do they have cardiac rehab at the hospital?
I believe they might have started that, so we'll be doing that when we go.
Yeah, that'll be good. Yeah. Because you're actually flying there Wednesday, aren't you? And you're going to meet, is it their health minister?
No,
on Thursday?
the health minister has been very kind. He met us on a number of occasions. He met us last time when we were there with the pacemaker team a few weeks ago only, and our pacemaker service has again been put on a firm footing, which is very, very, we are very grateful and thank him and the government for their support. He said that let's come up with a plan for a national cardiac center, and we have come up with some plans. But he's busy with a big WHO regional meeting this week. But we'll try to get a Zoom meeting or some other meeting with him. But I did contact some people from the Australian High Commission, so I am very fortunate that I'll be meeting them rather informally on Thursday, and I've met them before too, so we'll discuss some of the issues. And Australia is putting a lot of emphasis, input, and taking a lot of consultations in what they want to do for the hospital, CWM hospital.
Yeah.
And there's an Indian hospital coming up too at the moment in Fiji, or will be coming up. Yeah.
That's what, being built? Or?
Yes, the Indian government has very kindly donated a new. They were going to put up a new hospital in Suva. I believe it's about 100 bed, which will be, as they call it, the subspecialty hospital with a big focus on cardiology.
Oh, really?
Now, that is very, very good and very kind of them, I feel, But this is where my concerns arise, that you have another hospital offering something. Cardiac, Alex, very well. They go to an emergency department with their cardiac problems.
Yes.
That's where they need to be sorted out. And here we're trying to develop a cardiac service in this
A
country,
centralized one.
centralized service. And you have another hospital, how this, I think it would have been nice if there was a concerted effort, planning meeting, Australian hospital, big national hospital coming up, the Indian hospital, the development of the CWM, how far to take it, in a centralized, fully planned national medical center service, and that becomes regional too. Yeah.
Absolutely. Because or else
So
it just becomes diluted, isn't it?
yeah,
And they're all going to want the same needs.
that's
If
right.
another,
Particularly, this might become a. I don't know the full details, so I can only thank any country, any people, any organization that wants to help. And I've met Indian officials, and they're very, obviously, they're very well-meaning. How much medical input goes into all this is important.
because even if they're going to specialize in cardiology, that means they need cardiologists.
Yes, believe it might become a private hospital later. So that also, to me, raises concerns in a place like Fiji.
Yeah.
It
So
may all work out very well, but I'm not sure how much. When you plan a thing like this, cath labs are coming out in Fiji. Quite a few cath labs have popped up there. Imagine, cardiac surgical unit did not start at the Gold Coast Hospital for 10 years.
yeah.
You weren't allowed to put one in. You can't just set these things up until the whole infrastructure. Tweed Hospital is such a well-designed, well-planned hospital, but they are doing limited angioplasty, and they don't have cardiac surgery there. So, all these things need, of course, we're talking of different countries, but Fiji still needs proper planning into the development of these services.
It takes time and
Yes,
prioritization, isn't
yes,
it? I mean, you've got the emergency there,
Yeah.
you've got now the cath lab that's doing the angiograms and angioplasties, and then from that, really the next step is you need the cardiothoracic team in there to do the bypasses
Yes.
and the valvular surgeries. But to have a CTS somewhere else in a hospital without
My
the cath lab doesn't make
surgeons here
sense.
think it's a joke, that they can't understand how this happens.
Oh. So, fast forward in the next few years, what is it that you need, and what is it that would picture your most ideal situation in Fiji, and what do you need from the people, from the audience, from the government? What's your ideal that you'd like from them?
Very big question.
If I could wave a magic wand,
Yeah. I think proper strategic planning of healthcare, preventive services, um, getting the right mix of, the tertiary services. We definitely need them. I don't think we can go all the way to the most advanced. I don't think we can do heart transplants in Fiji. It's too much for
No.
Fiji. In an ideal world, we
it's
should
still
have them.
hanging on by sellotape.
Yes. So, we provide health, we provide our basic pacemakers, our angiograms, our angioplasty, our heart surgery for bypass and for rheumatic heart. That's in cardiology, whilst really strengthening the preventive aspects of cardiology. Similarly, in all other fields. And if this region could combine, in my slides I often show we have in Australia and New Zealand some of the best healthcare in the world. And you just have to take the plane eastwards or northwards, and you in many places disaster land.
Yeah, the disparity, and it's
the
such a
disparity
close
is terrible.
distance.
Yeah. So surely we can, as a group, these two countries with so many highly specialized, world-class doctors, nurses, technicians, we could come up with a plan to uplift healthcare at multiple levels.
At the region,
Yeah.
the whole Pacific
and
region.
educational too. I've always felt that the Fiji School of Medicine could have become a sister school of some of the Australian New Zealand medical schools. They have staff there all the time. Some form of staffing is there all the time. So attachments. And you could become as good a medical school as any in the region. Education is such a big part of our project.
Yeah. So really, you also need the funding. That's your another ideal,
Definitely,
and you
definitely.
want the Fijian government on board
Yes,
with continued funding, because it's fantastic that you've got all these private organisations and private individuals finding all these consumables and pieces of equipment non-stop continuously is impressive, going over with $50,000 worth of equipment each time that they fly over. But that can only be sustained as long as the enthusiasm continues, isn't it?
true.
There needs to
Yeah,
be a point where the government steps up and goes, hey,
yes.
we've also got
Yeah,
this.
I mean the government has said there will be more funding coming. You know, Peter and his colleagues are all. None of us are getting younger. We're all getting older, and to do so, I showed you the video of how this cath lab is installed. It's like heavy physical work. It's not sustainable. You can't. I don't think we can with this team. It's Peter and his colleagues, their goodwill, that has allowed us to put in 3 cath labs into the country, to get them out from their parent hospital here, put them in a container. I've seen this happen, and then storing this thing in some place and then bringing it to Fiji and doing all this. It's not possible. We cannot do this. So in the country where we have 3 private cath labs in Fiji now, brand new. We've got this brand new cath lab, Philips machine, in Lautoka. Another brand new machine coming up in a children's hospital. The hospital in the region that needs the best and the most advanced cardiac cath lab is the CWM hospital. It's running on shoestrings and all this second-hand, patched up equipment. Surely this cannot carry on, and
No.
should not carry on. It should be an affront to the government. No, we can't allow this to continue.
So, Vijay, what drives you to continue this work?
I don't know, madness. I don't know.
It's a huge part of your life, and it has been for many years. And it is your goodwill, it is your expertise. You've given a lot to this cause, and you're passionate. I can hear your passion in it. But what drives you at the end of the day to keep going?
Well, I suppose I'm from Fiji, right? I'm not born there, but I grew up in Fiji. I have a very strong affection, connection with the place where I grew up. My house, my school, my friends. Hospital was just 2, 3 houses away from where I lived. I worked there and I saw the need for this. And I still think it's not that difficult in Fiji to upgrade healthcare. And that's what keeps me at it, that surely we can do better. It doesn't take that much more. It is not easy, it's not cheap, but we can do a lot more and a lot better than what we are doing now. So that makes you sure. And I started this thing. I can't let go of it now. And the people, you'd go there. It's not easy to take this flight to Fiji. This will be my 4th visit this year, 3 to 4 a year. And do I have to go to Fiji again? You go by train or by car. You take your bags and pack your stuff and all that. And then you go to the customs and all that. But once you reach and you're on the road to Suva, you're home,
Yeah.
at home. So then it
Wow.
all fits in.
Any parting messages you'd like to give to the audience of anything maybe we haven't covered?
Well, there's a lot of goodwill out in the community among people, and I think when people combine and do things for a greater good, much can be achieved. And the more people join in these efforts, the more we can help people around us.
And if anyone wants to get in touch with you either as a cardiologist or to help you in the work that you're doing in Fiji, if anyone's listening to this that wants to help in any way, how do they get in contact with you?
Well, we have this Facebook page, Fiji Heart. I'm at the Gold Coast University Hospital. I'm at the Gold Coast Heart Center. Gold Coast Heart Center on the Gold Coast.
As a cardiologist, but Fiji Heart is where you do all your work.
For Fiji.
For Fiji.
But over here, I'm at the Gold Coast Heart Centre and Gold Coast University Hospital. Yeah, I think those are the best ways. I think,
Well, you are known as the leader of cardiology in Fiji.
Founder of some of the services, one of the founders. Yeah.
And I just think, the work that you're doing is absolutely wonderful. It's incredible. You're so giving of your time and your expertise to Fiji. Mm-hmm. And I just personally thank you for all the work that you do in this incredible space. I'm definitely going to come in February, March, whenever you're there next year.
Thank you.
I want to come and see, and if there's anything I can do and the team, more than happy to help you in any way possible.
Thank you so much, Alex, for having me. It's been a real privilege, and thank you for allowing me to share some of our work and our messages. Thank you very much.
Thank you. It's been fantastic. Thank you.
Thank you.
So if you liked this podcast, please like and subscribe to my podcast, Heartcore Junction. Alternatively, you can also follow me on Instagram. It's heartcore.group, and follow me on Instagram. Or otherwise, you can also book me for a workplace seminar where I'll come to your workplace and we educate on cardiac disease risk prevention and also the other diagnostics that are available today and blood work that can be done. Again, just look on my website, www.heartcoregroup.com, or email me on info@heartcoregroup.com. Thanks very much for watching, and until another episode, see you soon. Thank you.